Welcome to the HFMA Talk podcast, the podcast for NHS Finance. I'm Alex Hunt, Content and Social Media Executive at the HFMA. In today's episode, we're going to be sharing a conversation between Kathy Roe, Interim Chief Finance Officer at NHS Greater Manchester Integrated Care Board, and Jacob Lant, Chief Executive at National Voices. They discussed the need for a stronger relationship between the NHS and the voluntary community and social enterprise sector. Despite the government's indication that this will form part of the 10-year plan, ICSs are cutting VCSE contracts due to funding constraints, causing significant strain on the sector. This recording has been edited from a session at our Integrated Care Series event, which took place in early March.
I'm Kathy Roe and currently the Chief Finance Officer at NHS Greater Manchester Integrated Care Board. So this will be my 40th year in the NHS. There is just still so much that we can learn from one another about how we are trying to address a number of our challenges, and there's never been any greater challenge on the finance front than what we're facing into right now, has there? So just in terms of introducing our speaker, we are really privileged to have Jacob here with us today. So Jacob is the Chief Executive of National Voices. And Jacob will explore how integrated care systems can build on stronger relationships with the VCSE sector. He'll make the case for better integration and support, ensuring that the VCSE sector remains a key partner in our system transformation. So without further ado, Jacob, I will hand over to yourself and look forward to where you're going to take us for the next 15, 20 minutes. Thank you.
Thank you, Kathy. And I'll put my timer on so I know how long I'm speaking for. I am Jacob and I'm Chief Exec of National Voices. Now, if you haven't come across National Voices before, I'll just explain briefly who we are, because that can help then set the scene for the conversation. We are a coalition of other health and social care charities, about 200 or so in our current membership. And that really reflects two big sort of constituent groups. So we've got charities that cover conditions. So it might be the Stroke Association, Alzheimer's Society, so really big sort of national charities. It could be rarer clinical conditions, or it could be something that's like long COVID support, for example. So we've got one half of the membership are very much condition focused. The other half of the membership are very community focused. So they're often communities who are getting the worst experiences and outcomes at the moment from the services we provide. So the communities affected by health inequalities. So that could be particular ethnic minority communities. It could be people affected by addiction issues. It could be street homelessness. So there's a whole range of different communities in there as well. And we sort of merge those two together in National Voices to create a real melting pot of people with lived experience of conditions and from particular communities to help policymakers come up with better ways of designing services that work for people. And so that's kind of what we do. That's our sort of our bread and butter. What I was saying before the session started, though, is that often our conversations happen in the policy space, sometimes in the practice space or quality improvement, but rarely do we get the opportunity to speak directly to finance people. And obviously they're so intrinsically linked, and these worlds need to work very closely together. But just to explain kind of some of the sorts of things that we do when we get commissioned by either ICSs or the NHS nationally or the Department of Health, just give a sense of the sorts of work that we do. I would say on the one hand, you've got things like our contribution to big national strategies like the Primary Care Recovery Plan or the Elective Recovery Plan. And we really focus on how we can bring user voices into the room of the design of those strategies and those approaches. So we get our people with lived experience to say, what are the real barriers they're finding in accessing care? What is it they're worried about when they're sat on an elective waiting list? How can we help people get better and be in a better position ready for surgery? So we really kind of bring people into the heart of that sort of national policy design. We also do that work at a more sort of regional and local level. So we've recently done some work with some cancer alliances talking about why particular ethnic minority communities don't come forward for screening. And again, really working with those communities, trying to understand why certain people might be not engaging the way that we expect. And then lastly, I would say that we play a role at a very senior level in relation to things like the 10-year plan. So I have been advising and leading on one of the vision work streams for the 10-year plan, all about how we can create a more equitable NHS, which is very much got working with the voluntary sector at the heart of it. The things I wanted to touch on, first of all, was we know the environment is incredibly financially challenged. I don't think anyone on the voluntary sector side is under any illusion that the NHS is awash with cash and it can easily commission whatever it likes. So we recognise the difficult place we're in. However, there is also a big sort of national mood music about what the government wanting to see a much closer relationship between statutory services and the NHS. And you only need to look at the 10-year plan process for that. So there's a really strong message through all of the work that I've been involved in behind the scenes of the 10-year plan, all of the 4 vision strands of that exercise, all of which have talked about the importance of a new relationship with the voluntary sector that can help the NHS be closer to its communities, design services that are more accurately meeting the needs that are out there, helping to get ahead of demand that exists in the community, really supporting that shift to prevention. And I think there's a real mood music about how the NHS can work more closely with the voluntary sector, which is important for us to pay attention to, because there's an expectation there from ultimately the political paymasters of the direction they want to see us moving in. And it's not just in health. So the Department of Culture, Media and Sport and Number 10 are working on a new voluntary sector covenant, which is designed to build a set of principles about how the whole of the public sector should be working more closely with the statutory partners and together. Yet in the reality of this, we know on the ground that ICSs are incredibly financially challenged, and they are cutting the funding that they're giving to voluntary sector organisations. So there was a piece in the HSJ where I think they'd done a freedom of information request, and they said that 14 ICSs were on course to reduce their spend in this financial year, and that actually in some cases the cuts were as much as a fifth as they were expecting to spend on the voluntary sector partners. Having said that, there were also others in there who were massively increasing their investment in the voluntary sector. I think it was Staffordshire and Stoke-on-Trent said they were increasing their spend this year by 78%. So clearly there is like a real diverse range of opinions in ICSs about how much we should be moving towards investing in voluntary sector organisations to provide services and support. But I think if you take that national mood music about the 10-year plan, I would definitely be erring on the side of the Staffordshire and Stoke model of thinking about how do you creatively invest in that voluntary sector organisation in your patch. That's a bit of the kind of the where we are at the moment in terms of the finances. In terms of what the voluntary sector can do for you, I think it's also worth reflecting on that. Our first question I asked in the chat about what do you commission voluntary sector organisations to do? And I always think of it in the charities perform sort of 3 real functions across the health and care services. So one is about being commissioned to provide direct support. So that could be a mental health provision in the community. It could be rehab services, support with care navigation, might be a local patient transport provider. So actually the kind of the direct provision of services is probably the most obvious one that we do, and the one that's clearest to finance leads and commissioners in the NHS. The second is probably a little bit harder to get your head round, but it's still a really important role for the voluntary sector, and why investing it is so important is the role that we play in wider community resilience and prevention. So there'll be a lot of voluntary sector organisations that are providing things like exercise classes for older people, support for warm hubs during the winter, loneliness prevention schemes, and all of that is harder to commission because it's harder to put your finger on exactly what you're buying. And what exactly the outcome is, because what you're doing is you're investing in services that support that resilience, that are preventing problems further down the line. And there are questions as to whether that should be the NHS's job to invest in that. But personally, I don't think we'll ever get where we need to on the prevention journey unless we have a strong investment in those sorts of voluntary sector support. And it's the sort of stuff that the NHS shouldn't be doing itself directly, but does need to pay attention to. And the third and final area where I think there's partnership between the voluntary sector and the NHS is around that connection between community and decision makers. So voluntary sector organisations have a huge wealth of insight from their communities. They have a huge wealth of data. They often collect. They are often a much more trusted link. So they're often resourced and staffed by people from the communities affected. And therefore it's easier for them to engage with the wider community, and therefore so going through them is often a shortcut for an NHS organisation to do a necessary engagement and work with communities when co-producing and designing services. So those three things are distinct but all related, and I think we need to hold all of those in mind about how we work together. So whether that's providing direct support services, that wider resilience, or that providing that trusted links into communities, it all matters. I think on that point about the kind of that last point about the links into communities, all is so critical when it comes to tackling health inequalities. So we know that trust is a really big element of engaging communities who are getting the worst outcomes at the moment. They don't necessarily trust statutory services to have their best interests at heart, so they don't access care early enough, or they're nervous about accessing care. So only by working through the local voluntary sector partners can you do this. You do the sorts of personalised and tailored services you need to get the outcomes that we all want to see. So a good example with that might be hospital discharge services. So I know, for example, Pathway, who work with people affected by homelessness and addiction issues, they run a range of different hospital discharge services across the country, working with local systems to really help make sure that people aren't discharged back onto the streets, for example. That, I think, kind of talks about a bit about the relationship that we have. If I move now on to a little bit of some of the problems that I see, or certainly that members talk to me about, is we do see a lot of challenges in the way that the voluntary sector is commissioned at the moment. And I think a lot of these will resonate with you, because actually the asks that my members make are not dissimilar from the asks that you all make of the Central of NHS England and the Department of Health and Social Care. So firstly would be things like longer contracts. I know that the NHS is asking for longer financial settlements so that you have more certainty about how you plan and deliver the care that you want to provide to your communities. That matters to voluntary sector organisations as well. The longer contract, the more certainty we have, the more we can plan and make sure that we're delivering the services in the right way. And particularly the negatives when we get into cycles of 12-month extensions of contracts, which can be really disruptive to the way that voluntary sector organisations plan. And some of the delays that happen in decision making then lead to often charities having to make staff redundant. They lose vital knowledge and connections with communities as a result. So it can be really difficult. So that longer contracts point, you've got strong allies in the voluntary sector in helping the NHS make that case for longer contracts. The next one will be about reporting. So if you look at what's happened in planning guidance, you look at what's happened in the GP contract, the direction of travel is that government is cutting a lot of the targets it's setting for NHS providers. And that's a good thing, I think, because it allows you to concentrate. It allows you're less worried about the reporting upwards of what you're doing and more focused on delivering what matters to your communities. And the same is true for the charities that you work with. Yet it's not uncommon for us to hear members talking about spending 25 to 30% of the time in a project reporting to their NHS bodies on the activity that they're doing. Now, that's not a great use of that resource. We'd much rather that be spent on the front line, actually delivering support and services. So really think about the reporting structures that you put in place of how a provider can report to you on how they're doing. What is it you're really trying to achieve? I'll give an example of this on sort of realistic KPIs. So there was I was talking to a member who was telling me about an example of a local service for people with addiction issues that provided health checks for them. And it's set in the KPIs. It's at I can't remember the exact number, but the rate for do not attend appointments. And after a year of running the service, that they had a 50% DNA rate for people with addiction issues attending health checks, and it didn't meet the KPI because it was so out of sync with other services. Yet when you're engaging with people from that particular group, people who have often chaotic lives, can't struggle to engage in formal services, a 50% attendance rate is actually really successful. So that sometimes the services you're trying to provide can't be judged on the same against other services. So really think about the KPIs and what you're asking in terms of reporting for on contracts. And I think the last point is paying a fair price. I think there has been at times an idea that the voluntary sector delivers services cheaper, but I don't like to think of it as cheap. I think it's good value, because it's the range of added value that the voluntary sector partners provide, which is what matters. So don't think of it as trying to drive down the cost. Think of it of all the added benefits that you're getting if you go with a local voluntary sector partner over. So that kind of the main points I wanted to make. I'm going to give a couple of examples now, which I think are nice ones to share about examples of where working with the voluntary sector can make a difference. So the first one I wanted to talk about was the British Red Cross work on high intensity users of A&E. So I don't know if any of you come across this example before, but they have done a fabulous piece of work over a number of years, looking at the individuals who turn up at A&E repeatedly for whatever reason that they're attending. So it could be that and towards the end of life, it might be people who are again they don't access other services because they can't get a GP. They can't so that A&E is their default. It could be people are leading particular chaotic lives anyway, A&E is where they end up. They make up about 1% of the population, this group. But to put in perspective of A&E attendance, they actually make up 1 in 6 of A&E attendance across the board. So although there's a small proportion of the population, a big portion of those who are turning up and using A&E. And so I think if we think more about who is coming into our A&E departments rather than just focusing on our performance against the 4-hour A&E target, we start to look at the groups in different ways. And you can see for this group, they need more personalized support for their complex cases. So it could be about providing coaching of how they manage their condition and don't reach straight for A&E if something goes wrong. It could be about providing care coordination to them so that they know how to interact and navigate services better. Often the services are about meeting unmet social needs. So that could be issues to do with loneliness. That could be the fact that the housing that people are living in is not up to scratch and causing repeat admissions. So there's kind of all these sorts of different things that are beyond the NHS's immediate control in terms of how you design services, but they really matter and are driving these 1 in 6 attendances at A&E. But by building and working with the voluntary sector, we can actually create resilience amongst those communities. We can remove some of the practical barriers that they experience get in the way of accessing other services. The British Red Cross have been running a number of these high intensity use services to help people deploy self-management strategies. And the results from this stuff speaks for itself, really. So at the services they've been running, they had a 58% reduction in A&E attendances from this group, a 71% reduction in ambulance conveyance from this group. And the savings on that. So not only is it better because those people are not going to A&E, they're not spending a long time sat in departments experiencing poor care, but the financial cost savings is about 400,000 or so across each of the services they run, which was in terms of the cost investment in running that sort of high intensity use service and the extra support outside of the hospital, it was about a 250 to 400% return. So a huge added value by commissioning this sort of service run by a voluntary sector organisation. I'll share two more. So Maggie's is another one that I really like. I went to a Maggie's centre up in Cambridgeshire at the end of January. And I was attending a focus group for the 10-year plan, hearing about experiences of cancer patients. And they just have done such a fabulous job of being a service that operates alongside the NHS. So if you don't know Maggie's, they basically run cancer care drop-in centres where people can go and access all the holistic care that you might want to access. So that could be advice on personal finances. It might be advice on healthy eating and exercise to support you alongside your treatment. It can be peer support. It can be counselling, a whole range of different services all offered, which again, probably are not best delivered in the hospital, but are delivered in Maggie's, usually in sites alongside the hospital. And they're really developed beautiful settings that really think about the emotional side of the care need that people have. And a lot of the Maggie's staff are people who used to work in the NHS, so they're very familiar with how clinical and the NHS system can be. And that's great because the NHS needs to focus on delivering the best possible clinical treatment. But this holistic wraparound care is so important as well. So a recent study by York University looking at 3 Maggie's centres where they were providing that sort of psychological support I mentioned, and also things like pre-cancer treatment and exercise support. It showed that the local hospital trust, again, was saving roughly about £400,000 per year, helping to also reduce about 2,000 or so mental health, sort of talking therapy appointments, 2,000 oncology appointment hours. So again, you can see that the improvement here is that in the quality of care, but also that return it's having on improving efficiency of services and the financial savings that are being made. The last one I want to share is, I think is really interesting. So I was at an event listening to one of our members, Black Cancer Lives, talking about how they've been commissioned to run a screening service differently in East London to engage. It was black women with breast cancer, and they couldn't understand why the attendance rates for the screening were so low. And actually, all they did, and it sounds very simple, is that they recruited people from the community to run the outreach service. So they recruited black women to run the service, to provide the outreach, to provide the promotion, to go where the community people were, to talk to them, to do the engagement, and to be a trusted link and a trusted the trusted link into that community. And the attendance rate to the screening shot up significantly. So it's a very low cost service but it's also about thinking about who you're recruiting and who is the face of that outreach into the community. A voluntary sector organisation offers an entirely different way of doing that than the NHS trying to do itself. And so I hope those sort of 3 examples give a bit of a flavour of the things that I see in our membership.
The NHS Finance Event of the Year is back. The HFMA annual conference returns to London this December, bringing NHS finance professionals from across the UK together for 3 days of insight, collaboration and networking. Expect inspiring keynotes from healthcare leaders, engaging panel discussions, and the chance to connect with colleagues to discuss shared challenges and to celebrate the best of NHS finance. Super early booker prices have been frozen at 2024 rates, but are only available until Friday, the 11th of April. Book before then to get your tickets to the biggest HFMA event of the year at the cheapest possible price. Visit the link in our show notes to find out more and to book. Now back to the show.
Thanks so much, Jacob. That was, it was music to my ears, and it resonated hugely, actually, with at this time of year. Obviously, we are looking to work out what we can commit in our plans to deliver our strategies, and Greater Manchester prides itself on its strength of partnerships on integration, particularly with voluntary sector services. But even with all of that, the money being so tight, I can just see the squeeze and the pressure being put on all budgets, of which the voluntary sector are a part of. But we are really working out how we protect the significant part of the funding to make sure we don't go back on the delivery of those strategies, because we know just how much we rely on the voluntary sector service. But inevitably, there is some squeeze. How are the voluntary sector trying to mitigate that, is what I would say, because we all know the money isn't going to go far enough, and it's not going to cover all the costs that we know exist. And we know, many of these organisations aren't making any profit at all at the moment. So just in terms of helping make sure we don't do the wrong thing and start to actually stop some of these services, which I can see could be where some people slip into, which is obviously the absolute point we don't want to do. How is the voluntary sector responding to some of that to try and help come somewhere in the middle of the compromise, I think, to make sure that we don't end up doing the wrong thing? It's just that it's such a pressurised moment, and the NI thing is like a bit like the straw that could break the camel's back a bit, isn't it, with some of that?
Yeah, I mean, the NI decision has put a lot of pressure on the NHS. It's put a lot of pressure on the voluntary sector. It depends on the size of the organisation. So, for a really small community-based charity that's got sort of maybe 10 members of staff, or work part-time and there's a lot of volunteers, actually probably hasn't made a huge difference because of the sort of the relief that the government provides for small employers. Where it becomes more of an issue is if you've got a service provider type model and you've got a much higher number of staff in the voluntary sector organisation. So it's worth thinking through actually what does your voluntary sector infrastructure look like? Who's trying to segment it into who's being affected and who isn't? And I think that's a really good place to start. And in terms of how the voluntary sector are trying to mitigate some of this, I could talk a little bit from our own experience. So we are increasingly looking to industry to fund work that we do in terms of working with pharmaceutical sector, working with the technology sector on helping to bring user voice into those industries. But it draws us away from the services that the things the NHS needs our help on. And I think that's the difficulty, is like, how do we find the sweet spots of where we can all work together? Where is that so a good example of this might be on clinical trials, for example. One of the things we identified as clinical trials as a really big barrier is the cost of accessing the care, the cost of travelling to where the site where the trial is being delivered. That is the sort of thing that you could get a really interesting commissioning model where a local voluntary sector organisation is funded through the clinical trial to get transport to the appointment, provide holistic support to the people who are receiving it. It makes sure you get good adherence to the clinical trial, and it supports that, but it also supports the well-being and actually try to tap into some of that other sorts of funding. So that's another area, again, where we come together and we talk about what the options are. The worst thing that we can do is kind of retrench to a position where we don't talk to each other about what the challenges are, or that statutory partners can be in a position where, I know money's coming over the hill, I know it's going to get a little bit better next year, or there'll be more money kind of available to invest in that. So we'll just delay that decision by 6 months. That 6 months can be the difference between your supply chain existing and not. And I have that conversation continually with the Department of Health and NHS England about, yes, I know you want to do that piece of work, but if I don't get some money now, we're out of business in 3 to 6 months time. So it's about that partnership and that grown-up conversations about how we manage the money that is available best as possible.
Thank you. That's really helpful. How do you get through the door to prove the investor save opportunities in some way, given it to do some of this? Obviously, when we've said we know how difficult the finances are at the moment, but this is something again that I am pushing really hard for in Greater Manchester, because if we don't start looking more at the investor save and taking a measured risk, I would say everything is a risk with some things, but if we can see there is some really strong evidence or evaluation, and I'll come back to that in a minute, but around what impact some of these services can have, and you quoted a number of examples, how do you get to break down some of the conversation? Because I feel my feedback from some of my VCSE colleagues in the Northwest is it's really difficult to be able to find the appropriate opportunity to present just what potential there is there if you can contract and engage with the voluntary sector at the right scale and on the right services. The return on investment is huge. I mean, the A&E one is, prime one that we use all the time to say you've got a small number of individuals that the voluntary sector know the door number on the street of each neighbourhood that says it's these people that we need to be supporting and focused on, much more than the NHS or social care could ever get to spend as much time with, really, to prevent those A&E attendances. Have you got any advice in terms of how you can make sure the voluntary sector gets in front of the right people to be able to have the right conversations with the commissioners?
In that question, there's the complexity of the landscape. So I often hear people in the system, national and at ICS level, say that the voluntary sector is really confusing. I don't know, because there's so many providers, there's so many organisations in my patch. But for a small voluntary sector organisation, or even a relatively large one, it can be very confusing as to who in the NHS they should be speaking to. And they don't have necessarily the dedicated resource to be going around building that market for the commissions or the policy influencing work. So it could be really difficult. So I think making best use of the VCSE alliances is really, really important. But also talking to local authority colleagues and public health about sharing, each trying to share our own examples with each other about the things that we think are making a real difference. And you talked about invest to save as it's really interesting, because I think we're being increasingly channeled into this is if you take the A&E example as one, is that X spend on this thing in A&E will reduce attendances in A&E. So the invest to save proposition is very much within a service. And actually the real opportunity for invest to save is beyond that. So it's actually, I was talking about the community resilience stuff. That's really hard to prove the difference it makes. And it's hard to then roll out a consistent model. So in one patch, it might be a knitting club. In another, it might be a walking society or whatever it is. It's really hard to define what it is about that community resilience building that is making the savings elsewhere. But I think that's where we probably need to collectively think on what it is that the outcomes we're trying to achieve. Is the saving we're trying to achieve a reduction in the size of the elective backlog? Or is it a reduction in the waiting time for a referral, or whatever it is? They are not really the sorts of metrics and performance things that are going to drive us in a commissioning model that focuses on community resilience. Whereas a commissioning model that focuses more about experiences and outcomes, which is what the 10-year plan is sort of saying it wants to do more on experiences and outcomes, which is great. But if we move in that direction, we're going to need different investor save propositions. So I think getting a bit ahead of time and thinking about what are those outcomes and experiences that we want to drive will help as well.
No, thank you. And the investor save, as you say, it's a lovely term, isn't it? Because a lot of the time, what you think is being saved may not actually be cash releasable. And I know to a lot of people that will be something that's a dynamic that they are trying to manage at the moment. You are avoiding the next wave of demand coming in, which will then mean you are having to spend money in the way that you didn't really plan to, because we've got lots more on that demand coming in that isn't being managed in a different way. So you're preventing a huge move. Again, you're going against. You want to make sure you don't go against the 10-year plan, don't we? Because we're trying to make more hospital to home arrangements. And at the minute, the demand that's in the system is meaning we probably are, we all know we're spending too much in that acute end of care that we need to preventing people going in. I think in GM, we've estimated there's £600 million coming over the hill of unmet demand if we don't do something different. So that sort of focuses your mind in terms of that we have to make a difference, because we can't afford that. We haven't got that money to spend in that way. So I think it's making sure that it doesn't have to be absolutely cash releasable either. You're preventing something that will then allow you to spend your money differently in the future, isn't it? It's getting people's heads around some of that, I think.
I think one of the most sort of where you can get that prevention argument, but you can also show something that is cash releasable over a relatively short period of time, is around services that provide additional support at point of discharge of a point of diagnosis of a new long-term condition. So there's a big piece of the 10-year plan that's talking about agency, the importance of supporting people to, make most of their own capacity and skills to manage their own condition, and talking about those people's responsibility to manage their health. But we have to respect that agency. Not everyone starts in the same place. We've all got different levels of agency. But at the moment, when you get diagnosed with a new condition, it's not uncommon for people to be given a prescription, given a leaflet, and told to sort of go on their way. And they might find a charity to go and speak to for some additional support. They might not. They might find a friend or a family member or a local community group who've experiencing the same or not. Actually, if we provided more commissioned support at the point of diagnosis, that really worked out what's the level of support somebody needs, what sort of additional help can they provide. It could be with their level of literacy. It could be with the fact that they're a carer and or that they've got a particular job that means that their ability to attend appointments is really difficult. Whatever it is, we're exploring how we provide the support for them through that voluntary sector service. You can reduce the number of follow-up appointments quite significantly because a condition is better managed, but you haven't got that I'm just bloody confused about what's going on. Or the worst thing, which is I'm confused what's going on. I don't know how to interact with the service. There's quite a lot of barriers, so I'm just going to ignore it, and then the problem gets a lot worse. So actually there's something about that proposition about the invest to save, but how you manage demand. I think that point of diagnosis and working with a voluntary sector partner to provide wraparound support at that point offers a lot of opportunity.
I totally agree. Thank you. Is there anything you want to pick up that we may not have covered?
The thing that I'm most interested in is really, I know that everyone's so pressured. So you'll have your own examples of how you work with voluntary sector in your careers and in your past, but actually how much you are looking up, how much you're looking out to other systems for examples, how much you're talking to them about how they're working with their local charities of voluntary sector more in innovative ways. So, I mean, there's IVAR, which is an organisation, a charity that they do a lot of evaluation work for local voluntary sector organisations. They've done a huge amount of work on community health, which is incredibly linked to the whole neighbourhood health agenda right now. They've got stacks of examples of where stuff's worked really well. And, looking out for those headline examples and saying, well, what can I borrow? What can I steal from other examples is probably really, really helpful. So if people have got any thoughts on that, about where you look for other examples, that would be really helpful, because I don't know what it's like to be the day in the life of a finance person in the NHS, how much time you get to spend looking at those other things. Policy people spend their lives looking for this stuff. But I come back to that first point. How do we get the policy and the finance people to be more closely related? So, Kathy, I don't know where you look for examples for this stuff.
Yeah, I mean, and we've got through obviously the devolution era and what we've done subsequently, we've got loads of examples of where we've got some of this working to, different effects across the whole of Greater Manchester. And I think what we are looking to do is try and raise that to a consistent standard, because we can see very clearly from our helicopter view now that we are an ICS covering the system in the way that we are, things that are working much better in some areas than others. Now, as you said, not everything works in the same way for everybody. You need to make that bespoke in terms of what is actually required in some of these smaller neighbourhood areas. However, what I don't think we're great at, and you mentioned it earlier, is sharing good practice, even within integrated care systems. Before you even look to wider afield, there is definitely greater opportunity there to take the 3 or 4 things that absolutely are working. We can see a direct impact on how the rest of the system is performing on the back of this. That's the bit that we should be supersizing a bit. It's not rocket science, some of this, is it? There is opportunities there that we should be picking up now and running with. And so that's what we do. We're engaging with our voluntary sectors to understand what is it that we can do quickly to navigate some of these issues that we've got going on in Greater Manchester by using what's already out there. But there is a massive issue here with the capacity to stop and think, and as you say, look up and out for everybody. And I think that's what we are trying to dedicate more time to in order to be able to deliver on the strategies, because we're realizing that at the minute we're potentially sacrificing them for trying to deal with a very, very difficult financial settlement 1 year at a time. And it's back to your, we need longer term contracts. We need that resilience in place. We need to back the horses that we know really do work, and make sure that we aren't trading some of this in order to manage things in a way that potentially suit others. And I think we just need to hold firm. We need to hold our nerve a bit more at the moment, I would suggest, because the pressure coming down from on high on balancing budgets is so great at the moment. People aren't thinking in the way that we need to. And we need to make sure we don't make the wrong move some ways, because we'll pay for it massively going forward.
Yeah. I think also the neighbourhood health agenda is going to shift a lot of this. I mean, we know the shift to community, they want to achieve the shift to prevention. So the policy shifts are moving in that direction, and the structural shift around neighbourhood health. I think that's where a lot of the attention is going to go, about how we work in partnership with the voluntary sector and the NHS and local authorities, everyone together. So that's the space I would, if you're looking for really good innovative examples, I think that's really helpful. But remember, on top of that, we might want to commission national charities to provide, this could put some pressure on DHSC, NHS England, so to commission, say, Diabetes UK, because I used them earlier as an example. You commission them to run a national advice service on diabetes that plugs into all those neighbourhood health initiatives. There is something there that can be done nationally to help those to add capacity. But I think the real attention will be on neighbourhood health and where we can work together at that level.
Totally agree. That is the key thing for us at the moment. An awful lot that we need to manage in terms of getting the most out of what we can for these organisations. And I think the opportunity is absolutely directly in front of us now. This is what we need to grapple with. I mentioned before evaluation. That was in my head, because I think some people, they're not evaluating the right outcomes, as you said. And what the last thing I would say is work closely with your local authorities. Your local authorities have so much more information on individuals in your local populations than you would ever think, much more than what the NHS has. And again, there is a resource there that you could utilise much better than what most people are at the moment. Help look at what is the right level of interaction we want the voluntary sector to help us with, to help manage some of these key issues that we've got going on all around us at the moment.
Thank you to both Kathy Roe and Jacob Lant for their insights into the VCSE sector. We hope you found this episode to be both interesting and insightful. Our national event series is full of conversations like the one showcased today. Make sure to have a look at what's coming up on our calendar by heading to the events section on the HFMA website. That's it for this week's episode of HFMA Talk. Thanks for listening, Don't forget to subscribe so you never miss an episode. And if you've enjoyed the show, we'd love for you to leave a 5-star rating on your favourite podcast platform. See you next time.